PhD professor, tell us a little bit about your current clinical and research endeavors.
So I'm at the Stein Eye Institute at UCLA in the Department of Ophthalmology, and I also am in the Department of Human Genetics. My practice is in medical retina and ophthalmic genetics, so I deal with patients with age-related macular degeneration and other retinal problems, as well as hereditary retinal dystrophies and other actually eye genetic disorders as well. So I still see children as well as adults. I've been there about 9 years, and prior to that I was at the University of Pittsburgh for 17 years, and before that NIH, and previous to that Moorfields Eye Hospital. And I trained originally at UCLA. So my practice is non-surgical. I still do laser and anti-VEGF and anti-inflammatory injections for the eye. But a good chunk of my practice is with patients with age-related macular degeneration.
Tell us about the current thrust of your research in AMD.
So I started doing research in age-related macular degeneration 30 years ago, roughly. I started when I encountered an individual who had what appeared to be, they said it was a hereditary retinal dystrophy, but it in fact was age-related macular degeneration. And I realized that she had other family members and that this was really a genetic disorder. And that really started us on a 30-year journey to start finding the genes that were responsible for AMD. My group, when I was at the University of Pittsburgh, we collected a large number of families from all over the United States, and ultimately that led to the identification of the first genetic loci for AMD. Our mapping of one of the loci to chromosome 1 led to the CA complement factor H discovery by several groups, and we were responsible for identifying the genes on chromosome 10. Those efforts have later expanded now, and we've participated with international groups to explore the genetics of macular degeneration, which is a complex genetic disorder. That means it's not due to a single gene, but a combination of factors, such that the international consortium now has identified over 30 different genes and loci that are of genetic information that contribute to the risk of developing macular degeneration. And this has led to the discovery of pathways and biochemical processes that are now starting to work their way into clinical trials with medications intended to alter the biochemistry and hopefully the natural history of the disease. So I continue to work on a little bit on the genetics of macular degeneration, but we've shifted our focus in the last few years to how to combine the genetics with other biomarkers of very early or pre-age-related macular degeneration to identify individuals who are highly likely to develop the disease later in life, because ultimately those are the people where you want to have preventive therapies and institute them in a cost-effective and safe way that would protect them in the future. So that's really what our research does now, and I work in close collaboration with other scientists, both at UCLA and elsewhere, on those efforts.
Tell us about specific projects that you think are particularly noteworthy and promising right now.
Well, in our own area, and there's others working on similar things, I really have to give credit to Cynthia Owsley, for example, at U of Alabama, who has done some very good work with this. We're looking to see if there are early evidence of dysfunction of the retina prior to really developing disease that we can combine with the genetics to really form a much better way of predicting who's going to develop disease or not. So my colleague, Dr. Steve Nasinowitz, and I have, for example, developed a new instrument to look at the kinetics, that is the rate, how fast the retina can respond to dim light changes as a measure of rod photoreceptor function, as a way of trying to see if that's an early marker. What we've been particularly doing is using the genetics that we already know to divide our patient subjects into those who are at high risk for developing AMD and those who are at low risk, and then seeing if we can associate these physiologic changes with the genetic risks. And that allows us to sort of bootstrap our way up. Because obviously, if you want to study the disease at the earliest signs or before, you have to know who's going to develop it. And the genetics isn't perfect, but it allows us to start to ask that question. In other areas of AMD, obviously there's tremendous excitement going on in terms of treatments. Wet, as you know, has undergone a revolution of therapies with anti-VEGF therapies, but there are other groups that are now testing other blockers of pathways that lead to blood vessel growth that might improve our efficacy. And obviously a lot of groups are working on a variety of methods to try to deliver that therapy less frequently, because as many patients with macular degeneration know, when you're being treated for wet macular degeneration, it's very common to be getting injections into the eye every month, which can be quite tedious and discomforting and stressful for families as well as costly. So people are working on that. In terms of dry or atrophic macular degeneration, there is clinical trial underway, but even at this meeting, there are a number of papers and posters that are addressing various biological pathways that seem to be triggered in that disease, because we really ultimately want to prevent macular degeneration. I don't think most people realize that right now our treatment for the exudative or wet form of macular degeneration really doesn't stop the underlying disease. It only affects the activity and growth and leakage of the abnormal blood vessels. And that's a huge advancement. It's really changed things a great deal. But more importantly, we need to get at what's causing the disease to progress.
How powerful do you think an analysis of rod-dark adaptation changes is?
Well, interestingly, we did a study of that and published a paper where we used this concept of using, we refer to it as genetic endophenotypes, where we essentially took individuals who were at high risk for developing macular degeneration. They all had a family history. But we also had done the genetic typing of them. So we knew which individuals had high genetic risk factors, who was low. And then we looked at their dark adaptation thresholds, that is, how sensitive their retina was to dim light. And we found no correlation. So we've essentially, at that point, have put that aside, which is why we've now turned to this alternative approach of looking at the kinetics. And the analogy I tell people is that if you take two individuals, and one of whom has bad arthritis, and the other one is normal, and you have them walk down the hallway, basically, they'll both get to the destination. But if you have them run, you'll quickly tell who has arthritis. And so by looking at the rapidity with which the retina can adapt and respond to light is probably a more sensitive parameter, and that's what we're trying to explore now.
I think that's a very powerful distinction.
Yeah, well, we feel that all of these hypotheses need to be tested, and we thought that dark adaptation was a very exciting one. As you know, there's instruments that have been developed now to measure dark adaptation, and I still think that they'll play a useful role in monitoring response to therapy, because we know that dark adaptation is abnormal in patients with macular degeneration. But from our studies, at least at this point, we've not seen that it is useful to add to our predictive models as to who will develop macular degeneration.
Looking more broadly at other biomarkers, what looks promising?
Well, I think you have to divide the biomarkers into kind of two basic categories. There are those that represent specific alterations either in function or in structure in the eye, and then those that represent systemic factors. Because macular degeneration is really a combination of systemic and local issues. And so looking at it in that respect, there are a number of groups that are looking, as I said, Cynthia Housley's done some really beautiful work at looking at some of the functional aspects of the retina as an early biomarker. And then there are a number of groups that have been looking at things such as cytokine factors and the immunologic status of the body, because this is in some part an inflammatory and autoimmune disease. And so obviously getting the sensitivity and specificity may be challenging, but combining that with the genetics may give us the tools we need.
Turning to clinical best practices, tell us a little bit about your approach to treating patients and what you think an emerging best practice paradigm should be.
Well, there's still a lot of controversy in terms of how best to treat patients with wet macular degeneration. The original studies showed that monthly treatments, were by far the most effective at maximizing and preserving vision. And obviously, people, over time, that just becomes an exhausting process for both the doctors and the patients. Some people have gone to as needed, so when they see evidence of leakage, they treat. And the studies have tended to show that that's not as good, because when you allow fluid to reaccumulate in the retina, it ultimately leads to some damage and ongoing loss. In my own clinic, I use a sort of hybrid approach, which is very common in Europe, where we treat patients with a series of injections. If the person shows ongoing leakage in fluid, we just continue that series and checking every cycle. Several cycles of injections. We don't check every time. If they show that the retina has become more normalized and the fluid is gone, we actually continue the injections then for another 2 months, so that we have a period of time where we're confident that the retina has had a chance to heal and remodel without fluid being present. And at that point, I then actually often stop doing injections and just watch them very closely. And under those circumstances, I've had some patients go as long as 3, 4, 5 years without requiring additional injections, but it requires ongoing surveillance. So it's a matter of balancing that out. Now, that works for some patients and not others. I think one of the important things in terms, though, of the management of the patients is to realize and to be sensitive to how it changes their lives. The fact that for some people, what may seem to us as a relatively minor loss in vision is very emotionally and functionally debilitating, and they need support and help. That there's clinical depression often associated with vision loss, and that needs to be addressed. In other cases, you have patients who seem to keep going without really much hesitation with severe vision loss, and that's great, but you can't presume that that's going to be the case. I think one has to kind of listen to the patients and feel out how they are along the way. It's often very difficult as an ophthalmologist to get these patients to get to the services that they need, whether it's psychological support, treatment of their clinical depression. I personally don't treat people for their clinical depression because, quite frankly, it requires close monitoring and often adjustment of a variety of different medications. And in the elderly population, those medications have a great deal of side effects, so dosage is critical. But I do try to at least get their clinicians and their families to know what are the warning signs of clinical depression so that they can be attuned to it, and to also try to lower some of the stigma that's there about having that. And then the other issue is with social services and vision rehabilitation. I think many doctors wait way too long for referring patients for vision rehabilitation. They sort of help hold out that idea that their patient's vision is going to get better, and that may be true. I don't think we have to take away that element of hope. But for a person who has vision impairment, low vision services that allow them to maintain a more normal life style and activities is very important. So it's very useful to know where your resources are for that. And if you have access to social services to help them overcome some of the travel and other issues, that's very useful. That's very problematic for many of us to have that. But we shouldn't forget that that's important if we have those tools at our disposal.
You commented earlier that you see your patients more frequently than their internists. So you develop a much higher level of granularity about changes in their physiology and their perception of disease.
Actually, it's interesting. I mean, I get to know my patients very well, and that's really part of the joy of being a physician, is getting to know patients not just as a disease, but as people. They're fascinating. Most people have, at that stage in their lives, have done a great deal and have a lot of differences in experiences and opinions. But it's true, we actually, there have been times where I have, prior to their internist, detected the onset of other diseases that were not recognized because of the frequency with which I see people. I've diagnosed Parkinson's in a number of my patients, early Alzheimer's in some individuals. We've obviously are checking them for glaucoma and other things and have diagnosed that in a number of patients. But I've also picked up incipient transient ischemic attacks and other diseases. So it is an opportunity whereby just with a few seconds of time, one can really establish an ongoing relationship, because we do see them a lot.
Professor, you're truly a physician for all seasons.
You're very kind.
Thank you so much for joining us, and we will continue to watch your good work.
Thank you. I appreciate this opportunity.